Great. I'd like to welcome everyone to our speaker series. I'm Dr. Tom MacGillivray. I'm the Chief of Cardiac Surgery and Thoracic Transplant Surgery here at Houston Methodist. And it is a real pleasure to have with me today Dr. Ari Cedars, who was our Grand Round speaker. Ari is a cardiologist who specializes in adult congenital heart disease. And he gave a terrific talk this morning about durable ventricular assist devices for patients with adult congenital heart disease. So welcome, Ari.
Thank you very much, Tom.
And nice to have you here. I'd like to start out, could you just give us a little background about yourself and what got you interested in medicine, cardiology, and adult congenital heart disease?
So each of those is a separate question. I got interested in medicine probably later in life. Everybody in my family was a physician. My grandfather was a physician. My father and all his brothers and sisters are physicians. And I went to school, and the last thing in the world I wanted to be was a physician. I wanted to run as far away from that as possible. I actually was a history major, and I wanted to have a career in history. And ultimately, my thesis advisor told me, you know, if you're good at science, go do medicine, you'll have a stable career, you can always do history on the side. Maybe she was telling me something about my skills in history or my knowledge. So I ultimately ended up going to medical school. Didn't really like it that much. I decided that I wanted to do, and so in the summer after my first year of medical school, as like a summer job, I worked in a laboratory, did a kind of a laboratory internship, and I loved that. I decided, that's it, I want to be a basic scientist. I don't like this cardiology stuff. So then I actually applied to go to graduate school for biology. They're like, wait a minute. You have a history major and you have a minor in French and you want to go to graduate school in biochemistry? No. So the gentleman in whose lab I was working said, you know, you can still do research with an MD and as a cardiologist or as just a regular physician. You go do your internal medicine training, go do fellowship training, and select a fellowship that's got kind of a research bent to it. And that's what you should pursue while you're a fellow, and take some years to spend doing that and establish a career for yourself. And so I did. I took his advice, which at the time I thought was sage, and so I I did my residency at University of Michigan and then started fellowship at Washington University. And as soon as I was done with my clinical years, I went to the basic science laboratory. And I first worked on the training grant and then got my own grants to do some more work. And after 4.5 years in basic science, I was like, man, I've had enough. I became quite jaded with the whole process of basic science. And while I had been working in the laboratory, just through happenstance, I had wanted to maintain contact with clinical cardiology, and one of the older professors invited me to see patients with him in clinic, and he happened to be the provider taking care of the adults with congenital heart disease at Washington University. He's a man named Phil Ludbrook. And I loved it. I loved taking care of the patients. I loved the interactions that he had with his patients and the relationship that he had with his patients. It seemed to be unique and different from that I saw other cardiologists have with their patients. And so I said, you know what, if I'm going to return to clinical medicine, this is what I want to do. So I asked my division chief at the time, Doug Mann, if I could return to cardiology and do an additional year of training at the pediatric hospital, St. Louis Children's Hospital. And he said, sure. If you'll round for everybody on the weekends, you can go and do whatever you want. And so I spent a year doing rounding for the cardiology service on the weekends and got my congenital training and then joined the faculty in 2011.
Well, it's great. It's nice to see that no matter how you start or despite our best intentions that you end up in the right place.
That's right. Life is serendipitous like that.
But truly, for the audience, Ari is a world-recognized leader in adult congenital heart disease. Can you tell us about adult congenital heart disease? I mean, I think that the average physician and even many cardiologists think it's a niche practice. It's kind of studying one stone in the mosaic. Can you give us some thoughts on that?
Absolutely. So And I think that the average practitioner could be forgiven for thinking that, because it is relatively rare. It's probably 1% of the general population that has some form of congenital heart disease, and the majority of those patients have simpler forms, a bicuspid aortic valve, a ventricular septal defect, or an atrial septal defect. And the more complex forms of congenital heart disease are far rarer. And so it is a niche field, but it's a field that's growing. It's 1 in 40,000 live births, and patients are living longer than ever, and there are just a lot more years between 18 and death than there are between 0 and 18, so the adult congenital population is going to continue to grow. It is a heterogeneous group of patients. It's not one disease process, it's any number of anatomic abnormalities which are together lumped under the name of congenital heart disease. And so really what I am doing is seeing all of the breadth of pediatric cardiology practice, all of the breadth of anatomical abnormalities with which individuals may be born, the repairs which those individuals get in childhood, overlaid with acquired heart disease, with which most people are familiar, coronary vascular disease, late onset atrial fibrillation, heart failure. And so I see kind of all of those form the facets of what I take care of in adult congenital heart disease practice.
So why, as some people have asked, why shouldn't these patients, these adults who were born with pediatric heart disease, why shouldn't they just continue to be cared for by their pediatric cardiologist in their pediatric heart centers?
It's really a question of familiarity with acquired heart disease, as well as familiarity that we in the community are still developing with the kind of stereotyped and predictable ways with which prior repairs will deteriorate over time. Those are the kind of two unique aspects of adult congenital heart disease care. And just as an anecdote to demonstrate, I remember when I was doing my training at the pediatric hospital, and they had an ECG conference every I think 1 day a week. And they'd go through ECGs, and it's all in the pediatric practice, it's predominantly arrhythmias and vector abnormalities and such. And I remember at one time they showed this ECG, and all the pediatric fellows looked at the ECG and said, I don't know, it kind of looks normal, rhythm's normal, everything looks fine. And then the presenter, who knew I was the adult trained in the group, said, and Ari, what do you think of this? And I said, this patient needs to go to the cath lab. It was a patient with an ECG with an ST elevation MI. And it's just something that pediatric cardiologists don't see, because it's a part of what it doesn't happen very often in that population. And if it does, it's largely iatrogenic, and they kind of know when it's happened, or they identify that it's happened. And so I think that's just illustrative of a unique knowledge and skill set that we can bring to caring for our patients.
And you pointed out in your talk this morning that the number of adults with congenital heart disease are growing and has now surpassed the number of children with congenital heart disease. Can you talk about that a bit?
Sure. So probably since the late 90s or early 2000s, the number of patients born with congenital heart disease who are over the age of 18 has exceeded the number who are younger than the age of 18. And that's actually a testament to the success of our pediatric cardiology colleagues and of pediatric cardiac surgeons who have really, through remarkably ingenious developments, surgical developments, as well as excellent care, allowed these people who previously would have, by and large, died during childhood to live into adulthood. But and then they develop a unique set of problems that I in my field take care of, and I anticipate that the adult congenital population will continue to grow. Eventually, it will level off. I mean, the nature isn't making any more heart defects, and there's no new exposure in the environment that I'm aware of that's making heart defects more common. And so probably, there's going to be a backfilling, and ultimately it will probably level off at maybe 3 or 4 times as many adults with congenital heart disease as pediatric patients with congenital heart disease. But that really highlights another problem that we're just starting to address, which is the inadequate number of adult congenital heart disease providers in the community in the United States. When there are more pediatric cardiology providers than adult congenital providers, in spite of the fact that there are more patients with adult congenital heart disease. And so the medical system as a whole is really going to probably have to change to meet this increasing need in the Western world.
And we are seeing all kinds of issues that we never anticipated. I think many of these kids were fixed. They were patted on the head and sent on their way, but are coming back with any number of problems. I mean, today you gave a great talk about heart failure in the adult congenital heart disease population. Can you expand on that for us?
Sure. So we now know that, I guess it shouldn't be a surprise that anybody with chronic heart disease would experience higher rates of hospitalization than people who are unaffected by chronic heart disease. We know that patients with congenital heart disease are specifically getting admitted to the hospital with one of 3 things: follow-up procedures, kind of maintenance of whatever repair they had as a child, abnormal heart rhythms, and heart failure. And heart failure has a particularly nefarious prognosis. After admission with heart failure, as I was talking about earlier today, there's a 20 to 25% chance of mortality within 1 year. And so in recognition of that, if we want to do what's best for our patients, we need to start investigating what threshold we should use for taking that next step. When do we need to refer a patient with congenital heart disease for consideration for transplant, heart transplant, or mechanical circulatory support to help prevent these bad outcomes from happening?
Because I was struck by one of the things in your talk, that it seemed as if patients with congenital heart disease with heart failure are different from the traditional heart failure patient that we see. They go from being not sick enough to too sick for a heart transplant. Tell us about that some more.
Yeah, I think there are probably 2 reasons for that. One is just the population with heart failure tend to be probably 2 to 3 decades younger than those with acquired heart disease. And as a result, they have greater physiologic reserve, and they can kind of go along and function in spite of severe cardiac dysfunction for longer periods of time. But secondly, congenital heart disease is a result of the anatomic abnormalities and the repairs that go with the subject or with the area. It doesn't manifest always in the same way as heart failure in the general population. And frequently, congenital heart disease patients will experience heart failure that's attributable to right ventricular instead of left ventricular failure, the latter of which is far more common in the acquired heart disease population. Or in single ventricle patients, they have a unique way that they present with heart failure. And so as a result of kind of the unique presentation of heart failure and congenital heart disease, as well as the fact that it occurs at a much younger age, the identification and treatment of heart failure and adult congenital heart disease is going to be distinct from that in the acquired heart disease population. And we're really just starting to understand what thresholds we need to use to optimally treat, to optimally refer the patients before bad things happen, and then how to what therapeutic options are best for them. And unfortunately, neurohumoral modulation and goal-directed medical therapy, analogous to what we use and what has been so successful in the acquired heart disease population with heart failure, it has not been proven beneficial to this point in the adult congenital heart disease population. And so that's what our therapeutic armamentarium has fewer tools at its disposal.
In the dogma that you hear is, oh, you know, these patients, their anatomy is really complicated, and the results with transplant aren't very good, and so therefore, because of the limited resource of donor hearts, that maybe they're not best given to adults with congenital heart disease. Is that the dogma, conventional wisdom? I mean, you presented some very interesting information and data today that would refute that conventional wisdom.
Yeah, I mean, I think that may be the dogma, and if that's the dogma, it's wrong. Yeah. I can understand why people thought that for sure, but I think that congenital heart disease patients really, at least in recent history, do just as well as acquired heart disease patients with heart transplant, and in fact, probably do even better long term, just because they're healthier going into the surgery frequently. Their whole physiology is younger and better adapted. They haven't had decades over which they have abused their body or the environment has abused their body and have led to deterioration in other organ function. And so, and furthermore, they're compelling people. And I know that shouldn't be necessarily a criteria and it shouldn't change the care that you provide to a patient, but it makes me feel like I feel, and it may just be this relationship that I alluded to earlier that I have with my patients, but I feel attached to my patients and I want to fight for them. And so I guess what I'm trying to say is that yes, there was maybe some bias in the community that congenital heart disease patients didn't somehow, they weren't going to be as good a shepherd of the organ, or they weren't going to take as good a care of it. But I don't know that that's actually true, and I would vehemently against that bias.
So how can we, who are focused on caring for patients with congenital heart disease, adults with congenital heart disease, how can we better partner and message to the heart failure community how we can better take care of these patients?
To the greater heart failure community and to the general cardiology community, and even to the general practice community, I think the message should be that congenital heart disease is a unique problem and it requires specialized care. And there are warning signs that somebody unfamiliar with the field might miss, and that could be indicative that a patient is at a time when an intervention is necessary to prevent an adverse outcome. And so refer to a congenital heart disease specialist. Doesn't mean you're giving your patient away, but for co-management of your patient so that you know that you're doing what's right for your patient to provide them with the best care that you can.
How do you think as we continue to move forward, what are the exciting things on the horizon in the management of patients with congenital heart disease?
So that's a good question. The talk I gave today was about mechanical circulatory support in adults with congenital heart disease. Given the high incidence of heart failure in this population, I think that is one of the forefronts of kind of excitement for medical technology. But I think there needs to be a change in the way that we approach research for congenital heart disease. I think that the way that we've traditionally identified efficacious therapies in the acquired heart disease population with large-scale clinical trials, identifying the benefits of a drug based on an absolute risk reduction of 1 or 2% among thousands of patients. We're never going to do that trial in congenital heart disease. The population is far too heterogeneous and far too small. And I think that we need to really change the research paradigm. We need to identify outcomes that are more sensitive to clinical change than hard clinical outcomes, be they hospitalization or mortality. I think that we need to do a better job of identifying heterogeneity in treatment effects by specifically including patients at high risk for adverse events in intervention trials, so that we can augment event rates and augment the probability of detecting a beneficial effect. And I think just changing the whole research structure is really what needs to be done to start moving forward with identifying efficacious therapies in this population.
So you an advocate of multi-center societies-based investigation and collaboration?
Whether I'm an advocate of it or not, I think that that's the only way that we're going to get this research done, because, you know, all 10 of the patients with, you know, a dual inlet left ventricle that we may follow at my institution is not going to be adequate to do a meaningful clinical investigation.
Larry, I want to say, I, on behalf of all of us here in Houston, we really are honored by your presence, and we were educated and entertained by your grand rounds this morning, and it's a great pleasure and privilege to have you here with us today. I want to thank you very much.
Thank you. It's a privilege to be here. Thanks for inviting me.
Great. Thanks everybody for tuning in.